Good morning, class. I am Avenn Bandayrel.
Good morning, and I am Bea Elarmo.
Today, we are going to tackle the topic learners with difficulty moving or walking.
Right, Miss Aven. And this is focuses on learners with difficulty in moving or walking. It's focusing on physical and motor disabilities, the learning characteristics, abilities, and the support they need in an inclusive classroom.
That's right. And as future educators, it is important that we understand their needs and create an inclusive and accessible classroom environment for them.
Exactly. So let's begin. Are you ready, class?
Great, let's begin.
So, as I've said earlier, we will be tackling about the learners with difficulty in moving or walking. So, in this lesson, we will focusing on the physical disabilities like developmental coordination disorder, stereotypic movement disorder, tics, and the cerebral palsy. All of these are the example of physical disabilities that can cause challenges of the learners, also for the teacher and future teachers like us. So, in the particular discussion, we will discuss this type of physical disabilities. So, let's discuss first the developmental coordination disorder. Developmental coordination disorder. Coordination disorder, or DCD, also known as dysprasia, is a neurodevelopmental condition that affects a person's ability to plan and coordinate physical movements. This means that the brain has trouble sending accurate signals to the body, resulting in difficulties with both fine motor skills and gross motor skills. Okay, imagine your brain is like the control center for your body's movements. For most people, when they want to kick a ball or write their name, their brain sends clear messages to their muscles and everything works smoothly. But for someone with developmental coordination disorder or DCD, it's like those messages get a little mixed up or delayed. It's not that their muscles are weak or that they are not smart, but it's just that their brain has a harder time telling their body how to do a certain movement. So, TCD is basically when someone has ongoing trouble with movements that seem easy for other people. And can be with big movements like running and jumping, or this is what we call gross motor skills, or the small movements like buttoning a shirt and using scissors. This is the fine motor skills, and it is real thing that it can make some everyday tasks really tricky for them. Did you understand, class? Okay, so if you understand, we will going to proceed the stereotypic disorder. Stereotypic movement disorder, or SMD, is a neurodevelopmental condition characterized by repetitive, purposeless motor behaviors. These movements are often rhythmic and predictable, but don't seem to serve any clear function. Imagine someone who keeps slapping their hands or rocking back and forth a lot, even when they are just sitting or standing. That could be a sign of stereotypic movement disorder, or SMD. Basically, it's when someone makes the same movements or over and over again, and there doesn't seem to be a real reason for it. It's not like they are trying to catch a ball or dance. They just do it. Think of it like a little action that their body just repeats. It could be with their hands, their head, or their whole body, or even things like beating themselves. The important thing is that they do it a lot, and it can sometimes make it hard for them to do other things, like pay attention in class or play with friends. It's also not something they can easily just stop doing. Sometimes, these movements might happen more when they're feeling bored or maybe even excited or stressed. It's not the same as having a tic, like a quick blink or twitch, because these movements in SMD tend to be longer and more repetitive. So, SMD is all about those repeated movements that don't really have a purpose and can sometimes cause problems in everyday life. Did you class understand? again. So SMD is all about those repeated movements that don't really have a purpose. So if you understand class, let's proceed to cerebral palsy. Cerebral palsy or CP is a group of permanent movement disorder caused by early brain damage or abnormal development leading to impaired muscle control, coordination, and posture. The severity varies. It can be accompanied by other conditions. While there's no cure, treatments help manage symptoms. It's caused by issues before or during or after birth that affect the developing brain. Cerebral palsy or CP happens when the part of the brain that controls movements gets damaged really early in life, like before or right after someone is born. This damage makes it harder for the brain to tell the muscles what to do, kind or like having tangled wires trying to move your body. Because of this, people with CP can have muscles that are too stiff, too floppy, or that move in ways they can't really control. The main thing about CP is that it affects how you move your body, making things like walking or using hands more difficult. It's important to know that CP doesn't get worse over time. The initial brain injury stays the same, but how it affects someone can change as they go. There are different ways CP can show up. Some people might have more trouble with their legs, while others might have challenges with their arms and legs. Sometimes, because it involves brain development, people with CP might also have other difficulties with learning. Seeing, hearing, or even have seizures, you can catch CP from someone. And it's something people live with their whole lives. However, there are many different therapies and support that can help people with CP learn strategies and be as independent as possible. So, here's the classification of cerebral palsy. Here's the classification of cerebral palsy. So this is the sum of classification. So the monoplegia, hemiplegia, and triplegia, quadriplegia, also diplegia and double hemiplegia. So the description of this, the monoplegia is the only one limb is affected. So upper or the lower part of limb. So hemiplegia is two limbs on the same side of the body affected. So triplegia is three limbs are affected. Quadriplegia is all four limbs, both arms and legs are affected. Movements of the trunk and face may also be impaired. So the description of this, the monoplegia is the only one limb is affected. So upper or the lower part of limb. So hemiplegia is two limbs on the same side of the body affected. So triplegia is three limbs are affected. Quadriplegia is all four limbs, both arms and legs are affected. Movements of the trunk and face may also be impaired. Let's focus on the topographical classification of cerebral palsy or CP. By visualizing it directly on the body, the motor challenges are mainly in one limb, perhaps their left arm, which might be weaker or have less coordination than their other arm and both legs. This is what we call monoplegia. If one-sided of their body, for instance, the right arm and the right leg shows more significant motor impairment, possibly with increased stiffness or difficulty with control movements compared to their left arm and left leg. This is the hemiplegia. And if their legs are primarily affected, showing increased muscle tone or difficulty with coordination, making walking challenging, while their arms have relatively good function for tasks like using their hands. This is what we call diplegia. Next, if three limbs exhibit significant motor challenges, this could be both legs and their left arm, showing weakness or stiffness, while their right arm has more typical movement. This is the triplegia. And if all four limbs, both arms and both legs, demonstrate significant motor impairment, affecting their ability to move independently and often requiring assistance with many physical tasks. This is quadriplegia. The last one, if all four limbs are affected, the motor challenges are pronounced on one side of their body. For example, their left arm and left leg might be significantly stiffer and harder to control compared to the right arm and right leg, even though all four limbs present difficulties. This is quadriplegia. So, by understanding this topographical classification is fundamental because it directly informs our understanding of the individual's motor capabilities and limitations. Diplegia is legs are affected, less severe involvement of the arms, and double hemiplegia is impairment primarily involves the arms, less severe involvements of the legs. Occupational therapists and physical therapists conduct detailed motor assessments using standardized tests to evaluate coordinations and motor skills. These assessments compare a child's motor abilities to those of their peers to identify significant discrepancies, and therefore DCD identification relies on observing persistent motor coordination difficulties that affect daily life, begun in early development, are not due to other conditions, and confirmed through professional assessment. We are done in identifying DCT, start by noticing persistent difficulties with motor coordination that go beyond typical clumsiness. These difficulties manifest in both fine motor skills like handwriting and using utensils, and gross motor skills such as running and catching. A, a key factor is whether these motor challenges significantly impact child's ability to perform age-appropriate daily activities. So, the onset of these coordination problems is in early childhood, not due to an acquired injury or illness later in life. It's essential to rule out other medical or neurological conditions that could better explain the observed motor difficulties. So, parents and teachers often provide initial observations regarding a child's motor struggle in various settings. General practitioners or pediatricians um, they are play a crucial role in initial assessments and potential referral to specialists. Occupational therapists and physical therapists conduct detailed motor assessments using standardized tests to evaluate coordinations and motor skills. These assessments compare a child's motor abilities to those of their peers to identify significant discrepancies, and therefore DCD identification relies on observing persistent motor coordination difficulties that affect daily life, begun in early development, are not due to other conditions, and confirmed through professional assessment. This is the signs of developmental coordination disorder, specifically during early childhood and school age. In early childhood, toddlers and preschool years, so you might observe that these young children are slower to reach typical movement milestones like rolling over, sitting, crawling, and walking. They may also show unusual body postures during their first year. When playing, they might have difficulty with toys that require coordination such as stacking blocks, and struggle to learn to eat with spoons and forks. So, in school age, like elementary and middle school years, as they grow, as they get older and face more complex physical tasks, the signs of TCD become more noticeable. These children often have trouble with playground activities like hopping, jumping, running, and catching, or kicking a ball, sometimes avoiding these activities altogether. Fine motor skills are also challenging for them because leading to difficulties with writing, drawing, and using scissors, often resulting in messy or less developed work compared to peers. Self-care tasks like getting dressed, fastening buttons, and tying shoelaces can also be difficult. You might also notice they appear generally clumsy, frequently bumping into objects, dropping things, and tripping, or This is what we call oral. So, all right, class. Okay, all right, class. So let's clarify the connection between oral motor coordination and developmental coordination disorder. So remember that DCD is fundamentally about difficulties in planning and executing movements. Now think about speaking clearly or chewing food effectively. This action require very precise and coordinate movements of the mouth, tongue, and lips. This is our oral motor skills. Just a child with DCD might struggle to plan and execute the sequence of movements needed to catch a ball. They might also struggle with um, a sequence and coordinations of muscle movements needed to form a specific sounds when talking or to manipulate food. So, in their mouth while eating. So, the underlying challenge in DCD, difficulty with motor planning and execution, can manifest not only in lip movements but also in the complex movements of the oral motor system. Therefore, difficulties with speech, clarity of feeding skills can sometimes be seen alongside the more commonly recognized limb coordination problems in children with DCD. Alright, are you understand, class? Yes. So, did you know now the DCD and cerebral palsy, oral motor skills, and now we are going to proceed to another slide. So, oral just means anything to do with your mouth. So, your lips, your tongue, your teeth, your jaw, all of that good stuff inside around your mouth. And motor means anything to do with movement. Like when you ride your bike, you're using your motor skills to pedal and steer. So, when we put them together, oral motor coordination just means how well you can get all those muscle in your mouth to work together to a specific job. Like for example, blowing kisses. To blow a kiss, you need your lips to pursue just right and maybe a little puff of air. That's your mouth muscles coordinating. So, oral motor coordination is simply your mouth muscle working together like a team to do specific things. It what it's what allow us to eat, drink, talk, and even express ourselves with different facial movements. So we are done with oral motor coordination. Now we will going to proceed to stereotypic movement disorder or SMD. So to put it simply, stereotypic movement disorder or SMD is when a child repeatedly does the same movement without a clear purpose. So this often happens in toddlers and preschoolers, but it's also seen in children with conditions like autism. So sometimes these movements are the main issue and other times they happen because of another underlying condition.
Now, let's talk about learning characteristics. It is all about how motor difficulties and disabilities can affect a child's ability to learn. Motor difficulties and disabilities affect a child's ability to perform daily tasks, which includes memory, perception and processing, carrying coordinated movements, and even speech. As we know, our brain commands our body. There is a part of the brain which is responsible for our senses and thinking ability. We have the cerebellum, which is responsible for motion, motor abilities, and our ability to learn things, and the brainstem, which is responsible for involuntary movements in our body. Now, if ever there is a malfunction in this, especially the cerebellum, that could happen before or after birth, it will have a negative impact on our daily activities. For example, we ask our students to present a group dance performance, and from that, we can observe and classify the motor difficulties by just simply looking for those who can keep up with the beat of the music. Possibly because it's hard for them to recall the dance steps along with the music. So, what happens is that they tend to observe others while dancing. In this, children need to combine their senses and motor skills. Now, let's move on with the negative effects on students' psychosocial functioning. This is for the developmental coordination disorder or DCD or dyspraxia. Let's begin with the first one. Lower level of self-efficacy and competence in physical and social domains. It means that they can't control their own motivation, behavior, and social environment because it's hard for them to be with others. That's why it's hard for them to build a stable connection with them, which results in them being second, depressed and anxious. In reality, there are the types of students that are often not chosen in their fields of work. It is possible that because of this, they lower their themselves to the point that they might think that there are just dumbbells to others. That's why they don't want to belong to a group, and all of these can lead to depression that pushes them to come up with the third, externalizing behavior, where they are able to violate social norms that might already hurt other people. That's why it is this at this point, it's already hard for them because they are not just having motor difficulties, but also mental and emotional difficulties where they forgot to act properly due to the emotions that they feel. And lastly, the stereotypic movement disorder or SMD. It results in low self-esteem. In this, a person is underestimating themselves and their ability. A child prefers to separate themselves from others. Moving on, I will tackle what we call the range of strengths. Every one of us has our own strengths, and those strengths need to be recognized. Just like the students who have a motor movement disorder, where they may excel in other intelligence that are not controlled by motor functions. Since their weakness revolves around movement, it is possible that their strengths are in creativity or thinking skills that will bloom if they do really have the passion for it. They have adequate intelligence, credibility, and language skills depending on the severity of disorders. It depends on the level of their disorders in attaining the qualities and skills. We we need to make some adjustments for them to attain those mentioned skills. And it will be much more effective if there is a presence of a supportive adult. Like, for example, those who have cerebral palsy. Let's imagine that they could not move their arms until such time they learn to paint using their just to showcase their talent. And lastly, they need support systems that will give them equal opportunity to access learning experience in school alongside those normal students. As an inspiring educator, we need to make some adjustments on how we can meet their needs, how we can give them activities that will align with their strengths and weaknesses. After we identified the learning characteristics of children with physical disabilities, let's move forward to the general educational adaptations. First and foremost, we will discuss Kirk et al. From 2015. Children with motor difficulties and disabilities need primary intervention with specialists such as physical and occupational therapies. Physical therapies focus on helping people move their bodies and improve their physical function. For example, learning to walk again after a stroke. Next is occupational therapies. It focuses on helping people perform everyday tasks and activities of daily living. For example, helping your child improve his or her handwriting skills. These two therapists are responsible for setting goals in motor development, planning, and mobility, as well as providing teachers and others with information about the child's physical conditions, limitations, and abilities. Next is the physical accessibility of school and classroom to children with motor difficulties or disabilities. Ramps, elevators, and wheelchairs should be available to ensure all students can move safely and independently around school. Now, let's proceed to the types of accommodations. This presents practical classroom accommodations for children with developmental coordination, movement disorders by Pollock and Mizuna in the year 2007 and Beach in the year 2010. This is a table of classroom accommodation for children with developmental coordination disorder or DCD and stereotypic movement disorder or SMD. First is response. We can help our learners by doing assign a peer or adult as scribe for note taking, use different sizes of paper and graph paper to align numbers, try different writing tools and pencil grips, use a word processor or computer, use a text-to-speech programs, and allow for oral recitation or test taking to supplement written tests, and lastly, to provide alternate assessments and methods. In the end, our goal is to allow our students to demonstrate their knowledge and skills in ways that they are not hindered by their motor difficulties. This ensures that assessment focuses on what the student knows, not on their ability to write or perform motor tasks. Second is setting. We may assist them in overcoming their difficulties in the following ways. First is to allow them for preferential seating near the teacher, adjust chairs or desk height to maximize posture and stability, place a non-skid mat on the chairs, and lastly, to provide opportunities for movement breaks. Overall, the goal is to create a physical or instructional environment that reduces barriers and distractions, making it easier for students with motor difficulties to assess learning and to participate fully. The third one is schedule. We can help them overcome it by doing the following. First is to allow for extra time to complete tests and writing assignments, and to provide extra time to change for physical education classes. All in all, to give students flexibility in the timing and pacing of their work, reducing fatigue and also anxiety, and allowing them to perform at their best. Aside from what I mentioned earlier, there are also many ways on how we can accommodate learners. We may still have them manage their difficulties by this: photocopy notes and homework reminders for the child, allow to take photos of notes and the homework reminders, give advance organizers before a lesson or lecture to lessen or to remove writing tasks, and also send lecture handouts via email. The purpose of this is to offer additional supports that address unique needs and maximize the student's ability to learn and participate.
Thank you for listening.
We hope you were able to learn something valuable for our lesson today.